These three entities then play off each other, causing a vicious cycle, which can ultimately lead to multi-organ failure. We're familiar with those patients that often present to the ED with very similar presentations, but then have very divergent clinical courses. Some patients going on to recover very quickly, while others, seemingly similar initially, go on to develop multi-organ failure. Our lab has previously shown that these divergent clinical courses can be predicted and mapped out using multi-omics or proteomics and metabolomics, and then phenotyped. So we hypothesized that trauma patients who recover from shock within 6 hours will have distinct protein and metabolic differences at their initial ED presentation compared to those patients that remain in persistently shocked state at later times. For this study, we used our COMBAT database, and this comes from the COMBAT trial out of Denver Health. These were trauma activation patients at an urban level 1 academic center from over these 4 years. We had 144 patients available that had longitudinal clinical and multi-omics data. And 25 of these patients originally presented in shock with a base deficit of over 6, with subsequent samples available at 6 hours that we used for our study. 14 of these patients had sustained shock at 6 hours, while 11 of these patients had recovery from shock at 6 hours. And for our multi-omics analysis, again, we had blood from these patients at ED presentation as well as 6 hours. We ran it through mass spectrometry-based proteomics and metabolomics, and this yielded 111 different proteins and 430 metabolites for analysis. For analyses, again, we compared those patients that recovered from shock versus those patients that had sustained shock at 6 hours from ED presentation. We used a Fisher's exact test and a Wilcoxon rank sum test for clinical data, and we used students' t-test for multi-omics data. And those proteins and metabolites that were different at the 0.05 level, we then ran through Metascape and Metaboanalyst online platforms to discover pathways of importance. So looking at clinical variables, and again, a lot of this is limited by a very small sample size, but we can see those patients that recover from shock tend to be older and have more comorbid disease. However, this is likely due to the fact that they had lower injury severity scores and improved GCS. They had an overall similar blood pressure, but they did have a trend towards lower initial base deficit. As one would expect, those that recovered from shock had an overall greater improvement in their base deficit, and they had a trend towards requiring less blood products. And again, while we're limited by a small sample size, we can see those patients that recovered from shock overall had a trend towards greater ICU-free days, ventilatory-free days, and no mortality in their group. And while those clinical variables are limited by a small sample size, the power of looking at the biology and proteomics, metabolomics is that we can see actually pretty significant differences. And so this is a heat map looking at the top 50 different proteins in those patients that recover from shock versus those that stay in shock. And while this is a very large view of 50 different proteins, we're able to look through different pathways to see what is of importance. And so we can see that those patients that recover from shock have increased proteins related to adaptive immune response, namely immunoglobulins. But importantly, we can see that they have significantly decreased levels of proteins related to complement activation, immune system inflammation, platelet degranulation, and neutrophil degranulation as well. Looking at the 6-hour time point, we see a lot of these trends are stay true, again with increased levels of different immunoglobulins, and then decreased levels of the complement system activation, neutrophil activation, platelet activation, and overall inflammation. And looking at our metabolomics data, we can see those patients that recover from shock initially at the ED time point had improved metabolism related to antioxidants. And then when we look at the 6-hour time point, again, these patients that had recovery from shock, again, had improved metabolism with antioxidant pathways, but then they also had improved metabolism related to energy production, namely with mitochondria and beta oxidation of fatty acids. So in conclusion, we are limited by significant multicollinearity between our variables and limited sample size, so we could not use multivariable regressions for this. However, again, we did see in general, as one would expect, those patients that recover from shock tend to be less severely injured and have improved outcomes. But importantly, when looking at the biology, we can see that these patients that recover from shock do significantly have improved or decreased immune system activation and inflammation, improved antioxidant metabolism, and improved mitochondrial energy metabolism as well. Looking at some future work, we want to ultimately expand this cohort with a multi-center study to increase our statistical power and allow for multivariable analyses, expand to later time points to see these changes in proteins and metabolites over a greater time period, and ultimately continue what our lab is doing both in vitro and in vivo, looking at complement inhibition, platelet degranulation, neutrophil extracellular traps inhibition, and ultimately trying to restore the mitochondrial energy metabolism. Thank you to the entire trauma lab at CU for the help with this project, and happy to take any questions here this morning.
Just a quick reminder, 5-minute presentation followed by 3 minutes of questions. Great presentation. I just have one question. Why did you pick a base deficit to divide your responder and non-responder, perhaps?
Why did we pick base deficit?
Yeah, correct.
Just traditionally in our lab, that's what we use to mark patients that are significantly injured. We typically use an ISS score of 15 or a NIST score of 25, and we've always used base deficit of 6. We've ran these plasma samples through different in vitro studies looking at endotheliopathy, and that's where we tend to see the inflection point of causing endotheliopathy with these trauma plasmas is at base deficit greater than 6.
Got it. Did you have any discussion about using other markers, lactate, for instance?
We have traditionally always used base deficit. In our new sample size that we are collecting at the University of Colorado, we are using lactate just because we don't have an initial ABG as much. We tend to see those correlate about a lactate of 4 as base deficit of 6.
Go ahead, no.
Question. You have GCS 15 versus 5. I assume that's just because they're sick.
Mm-hmm.
How many of these people have significant brain injury? Because that's another comorbid thing that's not going to be in any of your biochemical markers here.
Yeah, so we did have TBI rates, which were just defined as intracranial lesions, hemorrhage or not, and those were statistically similar between groups. Again, looking at 14 versus 11 patients, they probably were different, but just didn't come out. Yeah.
For your future work, are you essentially looking at any specific proteins to help, with our decision making or predictability of recovery after shock, or kind of how do you see this in terms of its applicability with clinical care?
Yeah, so this is kind of hypothesis generating. We saw these different proteins that are looking at those patients that recover versus not, namely complement inhibition, which our lab has been interested in. So we're looking at different complement initiation pathways to then try to inhibit to prevent that buildup of the complement system, and also platelet degranulation and immune system activation. I think ultimately our lab's looking at these 1,000 different proteins and trying to create a quick point of care testing that will then use multiple proteins with the best statistical power, but not there yet.
Excellent presentation. Thank you.
Thanks.
Our next presenter, I believe, will be joining via Zoom. Dr. Diebel presenting detection of endothelial glycocalyx damage in shock conditions. What is missing?
Good morning. Can you hear me?
Yes, sir.
Yes.
I thank the Congress for the ability to present remotely this morning due to travel problems with my group. I was the one left holding the fort down, so that's why I'm not there. We have no disclosures other than that. Endothelial glycocalyx degradation after shock insults has been well described. The glycocalyx is important in both health and disease. It is known and felt to believe that these glycocalyx degradation products are go into the systemic circulation and contribute to the acute traumatic coagulopathy. What is uncertain whether these products actually have any anticoagulate effects in these patients. There's 2 papers that address this issue. The first one, which is often quoted, is a group from Denmark that describes degradation products following significant shock in clinical trauma patients, and showed that it was associated with endogenous heparinization. However, the only glycocalyx degradation product they studied was Syndecan 1. The group from Austria had looked at this using the ROTAM platform and failed to detect autoheparinization in their patients as well as in an animal study. TAG and ROTAM are very similar but different, and one of the differences is the different activators that are used. So the different activators may account for some of the differences in this data. The glycocalyx has been well described, and we've done it in our microfluidic models, and it's also been done in small animals. In clinical studies, endothelial glycocalyx shedding or degradation has largely been identified using plasma concentrations of these products in systemic circulation. We believe what is really needed to study this in a real-time fashion is a point-of-care methodology to study degradation in critically ill or injured patients. The liver literature indicates that there is an anticoagulant effect in the anhepatic phase in living donor liver transplant recipients, correlated well with the activated PTT. Another group had looked at whether you could use these glycocalyx degradation products to indicate that there is autoheparinization due to these, and it's uncertain whether that is true. It is well known since the 70s that there is an anticoagulant effect of both heparin sulfate and dermatan sulfate, but it's important to recognize that these products have 70 times less ability to cause anticoagulation in comparison to the heparin that we're all familiar that we've used for anticoagulation of our patients. And we studied in our model heparin sulfate because this accounts for 50 to 9% of the proteoglycans in the glycocalyx with a ratio of heparin sulfate to dermatan sulfate of 4:1. So we hypothesized that heparin sulfate in our model using TEG 5000 could identify anticoagulation or autoanticoagulation using increasing concentrations of clinically relevant concentrations of heparin sulfate. We spiked the whole blood samples with heparin sulfate from 0 to 100 micrograms per ml and looked at the R times, which is how you detect anticoagulant effect using the TEG platform. We also studied the difference between the Kalin activator, which is the intrinsic pathway, versus a native TEG, where no activators are used to see if there's an activator effect. First slide depicts the Kalin TEG versus the Kalin TEG plus heparinase. The Kalin TEG is in the blue, and the one with heparinase that blocks any kind of heparin effect. In yellow, you can see here, as we increase from 0 to 100 micrograms per ml heparin sulfate, there's a marked increase in the R time in Kalin TEG, and it's very much subdued when heparinase is used, indicating that this heparin sulfate at these concentrations does have a anticoagulant effect. If we look at the native TEG samples where no activator is used, a very similar pattern is observed. To further characterize it, we looked at the ratio of Kalin TEG to heparinase TEG. Previous studies have identified if this ratio is greater than 1.25, this demonstrates a significant anticoagulant effect when you compare it to other clotting studies such as the activated PTT or a ACT. And you can see here, even at 10 micrograms per ml heparin sulfate, there is this effect, anticoagulant effect noted. A similar thing was noted in the native TEG, but the results are similar, very similar as far as this ratio. If we looked at the rapid TEG, which uses two different activators, even when we increase the concentration of heparin sulfate up to 100 micrograms per ml, there is no change in the R time, reflecting that these activators overwhelm any mild anticoagulant effect of heparin sulfate. In conclusion, the results of our study suggest the use of activators may mask the effects of endothelial glycocalyx degradation products on TEG coagulation parameters. This is more evident with native TEG when comparing TEG R time with heparinase or Kalin. However, this study also shows that Kalin TEG plus or minus heparinase was sufficiently sensitive. We believe this latter comparison may be a novel real-time test to identify coagulation effects of endothelial glycocalyx degradation products in vivo, and this warrants clinical studies. Thank you for the opportunity to present.
Thank you, sir. Are there any questions?
I have a question. So obviously the utility of TEG and the trauma bay, it's all about timing, right? And so you really want that rapid. And I'm just wondering, what are you planning on looking at this clinically? Is it feasible to use this in a trauma resuscitation? And what are you guys planning to do at your shop with this data?
Well, currently we've switched over from using the TEG lysis cartridge and now using the TEG global hemostasis cartridge. as most of our patients don't have any evidence of elevated lysis, and using that cartridge alone, I think will be very helpful. And you can get this information early on, and it's usually within 30 minutes. And you do have an opportunity to study this in this setting. So that's what we're doing now or have done. And hopefully this ratio will pan out as a method to detect glycocalyx degradation products. Obviously, we're measuring these products in a lab setting as well.
Any other questions? Thank you very much, sir.
Thank you.
Perfect. Our next speaker is Dr. Risotto Urbanovics. She's going to talk about Be Aware of the Big Data, a lesson from data collection of houseless populations.
Okay, thank you for the introduction. We have no disclosures to discuss. So the houseless population is steadily growing over time with a 32.5% rise from 2022 to 2024, as seen on this graph here. Approximately 23 per 10,000 people experienced homelessness in 2024. And the CDC introduced mandatory screening for social determinants of health in 2024 as one of the 3 priority areas for healthy people in 2030. Current studies use a variety of methods when looking at this population, including zip codes, addresses, patient interviews, and some coding mechanisms and trauma registry. So we wanted to figure out how do we capture this data in a meaningful and accurate way, especially as we introduce these new coding systems in 2024. So there are many social determinants of health that were introduced in this time period or updated from 2021, which included problems related to education and literacy, problems related to physical environment, lack of adequate food or food insecurity. What we looked at was homelessness, which can include sheltered, unsheltered, inadequate, or unspecified. Sheltered being places that are meant for human habitation, such as hotels, motels, shelters, other people's homes for less than 14 days, whereas unsheltered is considered places that are uninhabitable, including tents, street, cars, trailers without access to electricity or water. And then problems related to employment and unemployment, as well as problems related to upbringing. So many things to choose from in your documentation and coding. So our aims were to determine the accuracy of current data sets on unsheltered and sheltered trauma patients using these codes, as reviewed on the previous slide, and then to evaluate utilization of nursing admission screening forms in concordance with chart review in unsheltered patients. So in essence, we did 3 things. We looked at Z codes that were queried, and we confirmed their housing status on chart review. And then we looked at nursing screening in the houseless population to see if this would be a better mechanism of looking at this population to determine the completion and accuracy. And then we did a chart review of all trauma patients from January of 2024 to July of 2024 to determine the number of missed patients. And what we found was that Z codes were inaccurately capturing housing instability. On the one hand, when we looked at the 226 patients who were Z coded as unhoused, 1 in every 5 patients were misclassified. So on further chart review, we found that they were actually had a home or a place to return to that was suitable. And then when we looked at the overall population, even though we were trying to capture this wide net of folks with the Z codes, we were still missing people. So 1 in 33 unhoused patients were missed in the general population, which you may think 3% is an acceptable rate of error. However, when this population represents less than 1% of all people in the United States, 3% is actually fairly high. And so then when we looked at nursing screening forms to say, oh, maybe that's a better way to capture this population, we found that it was actually quite abysmal. So in 234 patients, only 14% of those patients answered yes to the question that they were unhoused or had housing instability, whereas 47% were not completed and 39% said, no, I don't have any problems with housing, which may be an indication of how we're asking the question towards that population. And then when we looked at time, maybe over time, these nursing screening forms, got implemented and were better. That is not true either. And so over time, it almost was about the same as far as the number of uncompleted screening forms. So in conclusion, why does this matter? It matters because this is not just a big data set that we're looking at. These are our patients who are very underprivileged, very underserved, very underrepresented in our populations, and have worse health outcomes and healthcare access to our system. And so when we're looking at these patients, we really need to be cognizant and be responsible of the data measurement tools that we're using, and not just plug in ICD-10 codes to get thousands of points of data. And especially as we're moving into this current political climate, we need to make sure that in our own communities and in our own regions and hospitals, that we are continuing to look at this data, look at these populations responsibly. Limitations include this is a new coding, a new system, and it may take time to implement. And this is a transient population, which may be difficult to capture inherently. And so our future directions are improvement of hospital-wide screening and implementation, and continued education for all members of the healthcare team on documentation of social determinants, because this is how we accurately code those folks. And then overall, these are people that we're looking for interventions and looking to improve health outcomes. So when we responsibly find a way to find this population, then we can find points of intervention to improve their health. And that's it. Thank you.
Are there any questions?
I have a question. What are your recommendations for improving the capture of these social determinants of health? Is this something that should be in our trauma registries, and then my second question is, once you determine this vulnerable population, what are you doing at your institution to improve follow-up, better connect with these patients? Like, are you working on any sort of, community health or program implementation?
Yeah, so we currently have a street health community outreach program that is still kind of in its infancy. And they had actually, when we first started this project, we're starting kind of without a definition of the population or the problem or what kind of issues people were being discharged with. And so the second part of this project is we're trying to define those health issues so that we can work with that organization more effectively. And then for the first question, how do we do better? What we've found is actually asking the questions in a different way and being able to have our our APPs and people on the floor actually ask, because sometimes people get put in the system, like you saw for not completed. It was taking, like if someone's altered or comes in, it takes a couple days to actually be able to talk to them effectively. And so I think re-implementing maybe that screening at a different time during their hospital stay could also improve the data capture. So then
Thank you very much.
All right, our next presenter is Kavya Nathan, who will be presenting evaluating the outcomes of tranexamic acid administration among trauma patients without critical hemorrhage.
All right. Good morning, everyone. My name is Kavya Nathan. I'm a third-year medical student at the University of Kansas School of Medicine, and the study was conducted under the leadership and guidance of my PI, Dr. James Hahn. TXA is an antifibrinolytic agent that's utilized in the settings of known or suspected trauma for acute hemorrhage control. It has been established that the use of TXA is associated with certain complications, particularly thromboembolic events such as DVTs, PEs, and MIs. When specifically looking at adverse outcomes associated with TXA use in trauma patients, studies are varied in their findings. However, there's very limited data pertaining to the use of TXA in patients who are hemodynamically stable, thus not qualifying for the use of TXA in that setting. This leads to the purpose of our study, which was to explore the complications seen among trauma patients who received TXA in the absence of significant hemorrhaging, as indicated by clinical signs such as hypotension, hemorrhagic shock, and the activation of MTP. This was of particular significance in our county because of the widespread use of TXA by EMS, oftentimes due to the suspicion for significant hemorrhaging irrespective of clinical signs, thus driving our concern for any potential complications coming from widespread use of TXA in that regard. We included all adult trauma patients who received TXA in the noted date range, and patients were ultimately stratified into two groups, TXA indicated versus TXA not indicated, again based off of clinical signs for hemorrhaging. We had a total of 122 patients in our study. We performed our analyses primarily on a subgroup of patients to exclude those with 24-hour mortality so that complication rates could be reflected more accurately. About 81% of our patients were male, and we had almost an even split between patients who were white and patients who were minorities or of unknown race. Injuries were most commonly sustained to the extremities, followed by the chest, and then our most common mechanism of injury was firearm-related, accounting for about 34% of total injuries. And after patients were stratified, we had about 78% of our patients who did have an indication to receive TXA as opposed to 22% who did not. And in terms of initial TXA dose administration, this was most frequently performed by EMS in the pre-hospital setting, followed by about 26% of initial doses given at a referring facility. And again, seeing that almost half of initial doses were indeed given by EMS further affirmed our study purpose in terms of looking for complications that may come from such liberal use. And speaking of complications, we had 4 total documented cases of DVTs, 4 cases of MIs, and 2 PEs. Specifically looking at injury details, as anticipated, patients in the TXA indicated group did experience more significant injuries, particularly abdominal and vascular injuries. And looking specifically at hospital findings, again, patients as anticipated in the TXA indicated group also did have more complex hospitalizations as evidenced by variables such as the need for mechanical ventilation, ICU length of stay, as well as the need for certain surgical interventions. And now looking at the primary focus of our study, when looking at patients who were hemodynamically stable compared to patients with significant hemorrhaging, there was no significant difference in the proportion of patients who developed DVTs, MIs, and PEs when comparing those two groups. Thus, patients who were hemodynamically stable and still received TXA did not necessarily have an association with the development of a thromboembolic event. And as we can see, about 9 out of these 10 total cases were actually in the TXA indicated group. Looking specifically at our patients with DVTs, they also experienced more complex hospitalizations, as evidenced by some of the same variables as we saw before. Our patients with MIs were noted to be a little older, and all 4 of them had also sustained injuries to the chest. And lastly, our 2 patients with PEs had both sustained musculoskeletal injuries requiring orthopedic intervention. Ultimately, we had less than 5 occurrences of each vascular occlusive event. The intention of our study was to look at any potential complications that may come from administering TXA to patients without significant hemorrhaging. And our data suggests that the use of TXA in this population may not necessarily be associated with the development of thromboembolic complications. Limitations of note, certainly our limited sample size is the first one to emphasize, and specifically looking at our complications, having less than each of those thromboembolic complications does limit our power to be able to rely on a statistically significant association. One of our primary confounders was also the use of VTE prophylaxis for the vast majority of our patients. And lastly, unlike other institutions across the country, we also do not perform routine screening for DVTs, so any documented cases that we do have came from clinical suspicion and then diagnosis thereof. Overall, in terms of applicability, the use of TXA in the settings of trauma has become more prevalent component of many protocols throughout the country, and the use of TXA even in patients who are hemodynamically stable may be a relatively safe course of action. I'd like to thank the Southwest Surgical Congress for this opportunity, my PI, Dr. Hahn, as well as my mentors, Dr. Okut, Dr. Abla, and Ms. Kelly Lightwine. Thank you very much for your time.
I was wondering, how did you determine if TXA was clinically okay for the bleeding?
Right. So for our study in particular, we used first in terms of vital signs, like similar to like the STAMP or the patch trial, similar to their parameters. We use a systolic blood pressure less than 90 for one, looking at shock index greater than one, the activation of MTP after patients came to the hospital, or injuries that were significant enough to like warrant surgical intervention as soon as they came.
Similar to that question, did you find like any particular EMSs that were giving more TXA than others in your review?
That's an excellent question. I'm going to go ahead and defer to Dr. Han on that one. He is passionate about this, so.
Part of this was my bias with some of the best thinking. But this is
You got a small population that received TXA and were well injured, that their complication rate was the same as the higher injured group. And I wonder if the TXA that is leading to them acting more like a more injured group, and bigger study. And so then the next step is do a power calculation and figure out, is it feasible to do a bigger study? And you need 8 million patients to determine the difference, then it's not feasible, and that's okay, that's where we are. But I'm just curious, the big picture, what your guys' thoughts are.
That would have been yesterday at 12:30, but I had a couple of things, the multi-center trials. I really think we need to look at this. I absolutely agree with you. Because I already have that bias, I can't support this particular paper, but I really think using TXA like candy is a bad idea. I really do. When you see plastic surgeons using TXA like, what are you doing? Plastic goes crazy. This study is not obvious. But it's a separate.
All right, thank you very much. Excellent
Thank
job.
you. Thank you so much.
Our next study is by Dr. Yamamoto, optimizing resuscitative endovascular balloon occlusion of the aorta RIBOA outcomes using AI validation modeling of the Japanese trauma data bank.
Hi, I'm Ryo Yamamoto from Keio University School of Medicine in Tokyo and also the UT Health San Antonio. Today, I will be talking about optimizing RIBOA outcomes using the AI validation modeling of the Japanese trauma data bank. We don't have anything to disclose. So, as you may know, the randomized control trial in the UK indicated the potential harm of the use of the RIBOA in the trauma patient. So we don't use the RIBOA anymore in all trauma patients, even with hemorrhage. But still, there are several studies indicated some benefit of RIBOA, particularly in the resource-limited setting, such as combat theater and available operating room, and also lower-level trauma centers. So we aim to elucidate some indications or criteria for the use of the RIBOA based on the patient-related information. So this study, we used the kind of the AI modeling. It's a phenotyping study following these 4 steps. It's a little bit complicated. So at step 1, we selected the patient who treated with RIBOA from the data bank, and we calculated the estimated survival rate using the kind of the regression model in each patient. And also the probability of survival, the TRIS-PS, was calculated in each patient. And then at step 2, based on the difference between estimated survival rate and the probability of survival as a general trauma population, and we divided the patient into the 4 groups. So significantly higher survival than expected, slightly higher than survival than expected, and significantly and slightly lower survival than expected. So basically the patient with significantly higher survival than expected means if the patient were treated with reservoir, they had a benefit significantly compared with compared with when they were not treated with reservoir. Then at step 3, we identified the clinical features of the patient who had a significantly higher survival than expected, and also from the variables that had increasing or decreasing trends between 4 groups. And finally, at step 4, we validated these clinical features using another data set. It's another old Japanese data bank. So on the data bank, we used 2019 to 2022, and that included more than 250 tertiary care centers. We targeted only adult patients who were treated with reservoir, and to calculate the estimated survival rate, we used the survival to discharge from the data. So this is the result of the 4 groups. So on the left side, the patient with notably lower survival than expected. So they were likely to die if they were treated with reservoir. And on the right side, the patient with notably higher survival than expected. So they would have a maximum benefit from the reservoir. And we can find 4 clinical features. So GCS and systolic blood pressure on hospital arrival, and also the AIS in the abdomen and extremity pelvis. And you can see only those variables has an uptrending or decreasing trends across the groups. And so if you see the number of these variables in the patient with notably higher survival than expected, so on the right side, these should be the criteria for the reservoir use. And this is the validation. So we selected the patients from another data set defined by those who had all of these features and compare the patient with and without reservoir. So we found about 220 patients, and you can see the patient with reservoir underwent laparotomy angio more frequently, and also had a higher survival to discharge, 21.6 versus 7.3%. So as a conclusion, best candidate for the reservoir will have GCS 6 or less, systolic blood pressure 70 or less, and AIS in the abdomen equal to 3 or higher, and in extremity and pelvis 4 or higher. And the patient who had all of these clinical features had increment in survival rate more than 30% when they were treated with reservoir. Thank you.
Any questions? Yes, sir.
But there's a far higher proportion of ED docs placing it and surgeons placing it. And I know at least in our state with long transport times, which is not your problem, talking about having our ED docs or our perfect people place Reboas and transporting to our level. Do you have an idea, I realize you probably don't know all of this because I don't know any of this, but how many of these were placed by non-surgeons, how many people transferred in versus how many people ED have placed with you?
I mean, I don't have any detailed data, but I would say more than 50%. Yeah.
I guess my question was more related to the database. Now that do we place less Riboa in the US, therefore we don't have much data compared to
Sure.
Japan, or?
Yeah, actually, I looked into the data, the TQIP database. It's like back in 5 years ago, I think. And if we try to pick up the patient with who had all of these features, there's no patient had a Riboa in the United States. Yeah, that is very. I think this is that gonna generate the huge difference in the results of the Riboa study, because no one gonna have the Riboa in this United States if they had these, the clinical features. Probably they just go to the OR, So yeah, that's the difference, I think.
Probably we're talking with proven folks. I mean, we predict that too, but I think that would be a nice meshing because I think your data is way better than our data.
Interesting. Thank you. Yeah.
I have one question. It's a little nerdy, but talk to me about your AI modeling. It's kind of out of my wheelhouse. Is that something that you're doing in your large databases, or just provide a little bit of insight into that methodology?
So no, I didn't use the AI, but I just use the AI modeling system. So I basically do the same thing as the AI. So some kind of the AI modeling, this is one of the AI modeling, this is the phenotyping. It's just ask the AI to divide the patient population into several groups. Like this one, I divided the patient into the 4 groups based on the, expected survival rate. But after that, we can, anyway, the human needs to see what is the difference of these patients, like into the human language. So, I just use the AI, but it does not depend on the country's database.
Very good. Thank you so much.
Thank you.
All right, our next presenter is Dr. Joshua Smith, who'll be presenting Trauma Surgeons Stay at Home. The shock index fails to predict need for trauma intervention after ground level falls.
All right, good morning. Joshua Smith, I'm one of the residents from Baylor Scott and White in Temple, Texas, presenting this talk. Just a quick thank you to my mentor, Dr. Hall over here, some of the rest of our trauma department, and Dr. Regner over there. Hey, Dr. Regner, haven't seen you in a while. Miss you. Let's see. So is this the clicker here? Okay. Unfortunately, I have no disclosures. Just a little quick background. We all know that shock index is predictive of massive transfusion and increased mortality in trauma. I think some of us have probably had an inkling of this thought that the use of shock index in all trauma activations may overburden trauma teams. We specifically developed a hypothesis that the shock index is not a valid triage assessment for identification for need for trauma intervention, or NIFT, following ground level falls. Our methods, we did a retrospective review of all ground level fall patients greater than 60 years old at our ACS Level 1 Center in Texas. This was for the entire year of 2022. Our outcomes were selected to help define the true need for trauma team activation. The primary outcome, I'll go through this on the next slide, is the NIFT criteria, or need for trauma intervention. Secondary outcomes is dispo from ED to ICU of any duration of admission. The primary outcomes, transfusion within 4 hours, dispo from the ER to either the operating room or IR, dispo from the ER to the ICU with an ICU admission greater than 3 days, mechanical ventilation outside of operative intervention within 3 days of arrival, so primarily for respiratory failure, not for operative support, or death within 60 hours of arrival. Here are our first results. The main thing on this slide, you can kind of see the difference in patient population, a little less than 700 total patients. Those who presented with a shock index less than 1, we had 621. Those presented with a shock index greater than 1, we had 41 of those patients. As predicted, as you would assume based upon math, the heart rate and systolic blood pressure were different in those groups. We also noticed that the first creatinine level drawn was different, and the ISS was different between those groups as well. Interestingly here, the median ISS for the shock index less than 1 was a lot higher than that in the shock index greater than 1 group. You can see 9 compared to 1. Here's a lot of demographic data about our patients, just kind of showing that the 2 groups are relatively equal, a good split of male and female, and a lot of different comorbidities that we see quite frequently in Central Texas. Interestingly here, the percentage of these that were level 1 activations at our center is the highest level of activation. A much higher percentage of those shock index greater than 1 were level 1 activation compared to the shock index less than 1. The primary outcomes here, this is the meat of the presentation, kind of showing that the need for trauma intervention, there was no difference in the 2 groups. So the shock index didn't seem to be associated with a higher need for the trauma team to do something. No significant difference in transfusions. You'll see here that a decent percentage of patients in the shock index greater than 1 group did go to the ICU, but this was not necessarily the surgical ICU. This was all ICU, so it could have been the medical ICU or neuro ICU for non-traumatic injuries. There was no difference in mortality between the two groups. Here's a additional multivariate analysis we did that found that need for trauma intervention was correlated with injury severity score. And also the DISPO from the ER to the ICU, kind of representing patients who would need a higher level of care. Things like GCS, creatinine, and the ISS there were associated with need for an ICU admission. So conclusions, the shock index greater than 1 was not associated with a need for trauma intervention in ground level fall patients at our institution in Central Texas. We did find that there were increased odds of ICU admission based on clinical factors, but not the shock index. So injury severity score, GCS, and renal function. And just a thought for trauma centers out there, ground level fall patients should be excluded if a shock index greater than 1 is used as the determinant for your trauma team activation. So stop for any questions.
Dr. Stewart.
So that means you should not be using the shock index greater than 1 as the primary reason for activating a ground level fall patient as your highest level of trauma activation.
So ED, not trauma. Or trauma team 2.
However your institution would do it, maybe a lower level of a trauma activation. Yeah. Yep.
Yeah.
Great presentation, wonderful work. I kind of want to ask the follow-up to that last conclusion as how you think trauma centers could realize that particular criteria. Are ground level fall a separate activation strategy? And who is actually going to be able to do that level of critical thinking at a level 3 versus a level 1 trauma center?
So a couple different questions. I think in terms of who's going to do that level of thinking at those centers is different, right? Because you probably don't have a trauma surgeon in-house. Realistically, kind of changing the activation algorithms for lots of facilities, I think is going to take a little bit more research than just this paper. So it's going to take some additional studies that are done at different centers with different types of populations to kind of also hopefully demonstrate that the shock index alone shouldn't be used for that activation. We did change our institution's criteria after getting this data, and I think going back and making sure you did the right decision by looking back over, the following year's trauma activations and making sure that you're not under triaging people is important to do. So potentially, some more data in the future would be able to demonstrate, hey, we found this, we made this change, and we looked back and we saw that, we weren't exposing patients to more harm by changing their criteria. So hopefully that would give more, ammunition, so to speak, to other places that do want to kind of adjust their activation criteria. Because I think we've all walked down to the trauma bay at times and you can tell within seconds, you're like, man, I don't need to be here. But you want to make sure the patients are safe. So.
Yeah, hey, Fred Karachi, Denver. Great talk. I love asking a simple question like that. So when I think about the utility of shock index in elderly patients, because this was an older cohort, right?
Yep.
I think about unmasking occult hypoperfusion in someone who has undiagnosed hypertension and they walk around at 180. They come in at 120, which doesn't hit your hypotension criteria, but they're actually hypoperfusing.
Yeah.
So my question is, I don't know if you had enough with those 41 patients, but could you stratify by patients who came in with a shock index greater than 1, but not hypotensive, and see if in that specific scenario, it actually gave you some utility? Thank you.
I'd have to go back and look through that data to see if I could answer that question, but talking about whether the a true hypotension as opposed to just the shock index greater than 1 would be more useful. It probably would be, but have to look more into that. Good.
I understood your results correctly.
Yeah. Yep. So that's a question that I had initially, and then kind of looking at those numbers further down where the ICU is highlighted. So that's one of the things that would indicate you have a nifty criteria if you go to an ICU. And I don't know exactly what number, but a large amount of these patients were sick and ended up going to an ICU, more like a medical ICU, sick from like a sepsis type picture, but not necessarily trauma. But that was a question I anticipated. So because it is a difference, and it's true. If we had a larger sample size, could a difference be parsed out there? It's possible, but I think based upon the fact that the ICU admission numbers contributed to most of those, probably unlikely. But
do you look for cold type of confusion? At least for us, if anyone's over 65, everybody gets lactate. Or exactly the reason. So that would be something to really add in favor.
yeah, we do. I don't know if we had lactic in our numbers. I don't think we did, but I think that comes down to this where we did find there's a difference in like creatinine. A higher creatinine on presentation would reflect a cold hypoperfusion, leading up to that presentation, as the underlying thought that we all have is this person is sick from something else and then they fell and they don't need a trauma surgeon. So I think the creatinine level would kind of reflect that, true underlying occult hypoperfusion that precipitated the trauma mechanism. So, but that's a good thought. Yeah.
Excellent job. Thank you.
Thanks.
Our next paper is by Dr. Molina, The Effect of Full Moon Phases on Major Trauma Incidents and Outcomes, a multi-year retrospective analysis.
Hello, everyone. Thank you for your time. I'm a third-year medical student out of UC Riverside School of Medicine, and today I'll be talking to you guys about our research on the lunar moon phases and if they have any influence on trauma incidents. We have no disclaimers. And a little bit of background. So this idea that full moons affect behavior and presentations isn't something that's relatively new. It's actually quite ancient. This idea comes from the Mesopotamians and actually Greek and Roman philosophers, specifically Aristotle and Pliny the Elder, who thought that like the moon affects tides, it also affects brains because they were made mostly of water. This is embedded in our language as well. The word lunatic, derived from Latin, actually means to be affected by the moon. And physicians are not immune to this idea. Actually, back in the day, they used to make contraptions to monitor the moon cycles. Here's an example of one of those that's displayed at the Royal Observatory in Greenwich. And what they thought was that on full moons, patients had a greater magnitude of fevers. So let's talk about today now. So I'm sure everyone here in this room has heard or has a story themselves about a full moon shift, whether it was a messy trauma or just a really busy day. This idea is actually even ingrained into a pop culture, but also it's in our literature. So in our literature review, what we found were 6 peer-reviewed studies. 5 of those 6 found no difference, and 1 did. However, it was mostly looking at psychiatric admissions. So we wanted to see so far ourselves. We utilized the Trinetics database from the years 2014 to 2023, and we compared 2 groups, patients presenting to the ED on full moon days and patients who did not. And we determined those full moon days based on a NASA-verified lunar phase calendar. The variables we were interested in were traumatic brain injuries, trauma by anatomic location, and mortality. And we extracted this data, put it on Excel, and essentially compared rates because there's more full moon days or not full moon days than there are full moon days. So we were looking mostly at proportions. We set our significance at 0.05. Here's a peek into our demographics. If you see the very bottom row, that's the totals and then the mean age. So mean age of 46, and we essentially just wanted to ensure that the proportions were roughly equal. Our hypothesis was, you can guess, that injuries would not differ on full moons versus non-full moons, although everyone says differently. So here's a peek into our data. What you're looking at here is a logarithmic graph. And if the number is closer to 1, it means that it happens more often on a full moon. And if it's closer to -1, it happens on days that are not full moons. So consistently, surprisingly, there was this pattern of more presentations of traumatic cerebral edema and diffuse traumatic brain injury. on full moon days, while on non-full moon days, there were a couple of significant findings on focal traumatic brain injury. And here on the next graph, we aggregated the data into 10 years, and then we compared the 10 years data as well, more like a bird's eye view. And we see those consistent findings of focal traumatic brain injury and traumatic cerebral edema occurring. Here we looked at our anatomical locations, and we found, there's a few signals. However, outside of that, there was really no difference. The one finding we did have, this is the aggregate 10-year, we see the open or depressed skull fractures occurred more commonly on non-full moons. So here's our mortality. We were looking at mortality, and we saw in 2017 and then 2020 onward, there was more mortality on full moon shifts than there were not. And here's a graphical representation of that. If you see that the dip in 2019 due to COVID-19, and the error were roughly within margins, so we feel like there was no significant difference. Although there was a statistical difference, we feel like it wasn't clinical. So to get into our discussion over the 10-year period, there was no clinically significant difference. However, if you looked more into a pinpoint view year by year, there was a statistically significant variation, mostly the traumatic cerebral edema on full moons. However, on non-full moons, we found that there was more open, depressed skull fractures, facial fractures, mortality, and other injuries showed no differences. So the limitations were mostly surrounding our database and the inability to control for confounding variables. We couldn't assess for injury severity score. And we were not really too sure. Basically, the database is all surrounding like ICD-10 codes, CPT codes. So we couldn't determine whether the patients had complications after they were admitted or if they died from injuries within the ER. So to conclude, we found, or we believe that there's unlikely a biological or physiologic effect from the moon, but there rather is potentially some indirect effect of the lighting of the moon, potentially people being out more on nights where there's more visual ability for you to be out, I guess. And we did see some anecdotal findings, but they remained inconsistent and correlational. And lastly, we believe that this is more of a cultural rather than clinical effect. Thank you for your time.
Are there any questions, Dr. Stewart?
I'm just asking you to speculate, because I think I would rather than culture, I might call it historical, because I would guess there might have been a time before ambient artificial lighting that exists everywhere in the world, pretty much today. I would guess that there was a time when basically, the light of the moon did give lighting for people to get out and do more. And then if you're out and everyone knows if you're out and doing more, you're more likely to get injured. So I just ask you to speculate on that.
Yeah, no, I feel like that sounds quite accurate. I did a little bit of a historical review as well, just because I was curious. And it did seem like these ideas were mostly, I think, around the 1600s, 1700s, where you see that these ideas started. So that definitely could be what this is coming from, yeah.
We know if you went a little bit west of here, let's say 500 miles west of here, there was a culture that dominated the plains for 5 centuries or 3 centuries. It was the Comanche people, and they specifically used the light of the moon. So the Comanche moon references because they were out and fighting at that time, and so I do think our ancestors, where they talked of lunatic and they had all this stuff, probably had more practical related to life, as you said.
Yeah.
Very interesting.
Dr. Wagner.
Just Wagner, for the organizer. I would encourage you to continue along this and become like the sort of Buster. big data decide, are we, it's
I had a really quick question. I'm curious if you looked at mechanism of injury, like what should we be telling people not to do when, I mean, did that bear out in, I mean, you speculated about people being out. I mean, looking at facial fractures, open skull fractures, I presume assault, but I mean, did you look at mechanism in this database?
It was because the way that like the coding works, it's kind of hard to look at it in that lens. I mean, there's an ability to. I don't think we specifically like looked at it just due to like the small numbers of patients within each category. The database gets updated every day, which is actually kind of cool. So let's, I don't know, a year from now, there might be enough patients to do a study like that.
All right, our next presenter is Dr. Mohammed Al-Ma'ani, who will be presenting Does the Balloon Rise Up to Our Expectations? The Volume Outcome Relationship of Reboa Over the Years.
Good morning. Thank you for the privilege to present our work. I have nothing to disclose. Hemorrhage is the leading cause of early death in trauma patients. Resuscitative endovascular balloon occlusion of aorta is used as an interim measure to control exsanguination. However, current evidence on outcomes of Reboa is inconclusive. Although multiple studies have described the outcomes of Reboa in trauma patient, still limited data on volume outcome relationship in Reboa. We performed this study with the aim to evaluate trends in utilization and volume outcome relationship in Reboa. We hypothesized that increase of Reboa volume in trauma centers is associated with less Reboa-related complication and mortality. We performed 5 years retrospective analysis of Trauma Quality Improvement Program, TQIP, which is the most comprehensive trauma database maintained by ACS, with more than 800 participating trauma centers across the US that tracks over 300 variables about the in-hospital course of patients. We included all adult trauma patients who received Reboa. And trauma centers were classified into tertiles based on the number of patients undergoing Reboa into low volume, middle volume, high volume trauma centers. Our outcomes were rates of Reboa-related complications, which were defined as acute kidney injury, lower extremity compartment syndrome, and amputation. We also looked at the rates of mortality. We performed the following statistical analysis. Over 3,000 patients met our inclusion criteria and were divided into low volume trauma centers, middle volume trauma centers, and high volume trauma centers. Looking at our study population baseline characteristics, we found that there is no statistical significant difference in terms of demographics and ED vital signs across the 3 groups. As per trauma center verification level, the majority of the patients were treated at level 1 trauma centers. In terms of injury characteristic, the most common mechanism of injury was blunt, and most of the patient was severely injured with median ISS of 27. However, there was no statistically significant difference in terms of injury characteristic across the 3 groups. On univariate analysis, when we looked on the median number of inserted Reboa in trauma centers, we found that the highest number of Reboa was in high volume trauma centers, followed by middle volume, then low volume trauma centers. We also looked at the time to median time to Reboa, and we found that the lowest time to Reboa was found in high volume trauma centers, and the highest time was found in low volume trauma centers. In this graph, we can see the Reboa-related complications with red color representing low volume, blue middle volume, gray high volume trauma centers. We found that there was no statistically significant difference across the 3 groups between the years 2017 to 2021. When we looked at the mortality rates, we found that there was a statistically significant difference across the three groups between the year 2017 to 2019, with highest mortality rate found in middle volume trauma centers. However, there was no statistically significant difference in the years 2020 and 2021. After adjusting for confounding factor, we performed multivariable regression analysis to look into the independent predictors of increasing volume of RBOA to outcomes. We found that there was no association between increasing of volume of RBOA related to complications rates or mortality rates. In conclusion, no volume outcome relationship with mortality or RBOA related complications was found over the years. Patient selection is still evasive in RBOA, and further efforts should be made on appropriate selection of RBOA patients. At the end, I want to thank my mentor, Dr. Bilal Joseph, and the Trauma Division at University of Arizona for their constant support. Thank you.
Any questions? Dr. Hess?
So probably can't answer this question, but those times being from a center that was a high, that we gone to low, and we had amputation. 60 minutes versus 30 minutes seems awfully high. I mean, normally we talk about putting in the sheet just in case you need it, and placing the result. Do you have any thoughts or ideas on why that seems to be a discontinuity? I mean, normally we're putting a sheet in 5 minutes.
Sorry.
So in TQuip, do you have any idea? I realize the data probably doesn't lend itself to this, but do you have an idea, or your facility, like, do you use RBOA? Do you have a protocol? Any thoughts on why it's taking 60 minutes for the RBOA? Because it's 60 minutes out of it, I mean, I have no business.
Yeah, and in our institution, we don't use RBOA in trauma bay. If it's used, it will be used in the OR. So probably no. Yeah.
Did you look at the subpopulation of pelvic hemorrhage, zone 3 deployment? I mean, did you look at these patients by zone of injury or zone of deployment or injury type, like pelvic hemorrhage, or not?
Oh, no, we didn't look into that, but
it's not in TQuip. Okay. Yeah.
Thank you very much, sir. And then our last paper of the day is by Dr. Stenberry. Colon injuries in the era of hemostatic resuscitation, does transfusion burden still predict anastomotic leak?
Good morning. Thank you so much for the opportunity to present. My name is Brittany Stansberry. I'm a fourth-year general surgery resident at Creighton University, Phoenix. Today, I'll be presenting colon injuries in the era of hemostatic resuscitation. Does transfusion burden still predict anastomotic leak? Management of destructive colon injury with resection and anastomosis is generally recommended in the modern era. However, colostomy or proximal diversion is reserved for patients with compromised perfusion from shock or medical comorbidities. Historically, the transfusion surrogate of greater than 6 units of red blood cells has been used for a surrogate for shock to guide whether or not colostomy or proximal diversion should be considered in these patients. This surrogate was established in the 1990s. However, in the modern hemostatic resuscitation era, patients are now receiving blood products up front, and there's a propensity to use less crystalloid. Our goal was to determine whether or not perioperative transfusion volume still correlates with anastomotic leak after destructive colon injury in contemporary practice. Our study is a retrospective single-center analysis at our ACS Level 1 Trauma Center in Phoenix, Arizona, conducted between 2014 and 2023. We included patients that had a colon resection with anastomosis, and we excluded those who died within 48 hours. The majority of our study included 60 patients, the majority of which were male, and with an average age of 32 years. 6 of our 7 leaks were from the male subgroup as well. And our demographics can be seen below. This is representative of our center's typical ethnic groups. 42 of our 60 patients, or 2/3, had a penetrating injury, and 2/3 of them had an injury severity score of 16 or greater. In the leak group, 5 of the 7 patients also had a penetrating injury as well. 9 of the 60 patients underwent damage control laparotomy. 34 had a colocolonic anastomosis, and 23 had an ileocolonic anastomosis. 5 of the 7 leaks came from the colocolonic anastomosis group. Over 2/3 of our patients received blood transfusion with an average unit of 4.5 and total components of 14.4. You can see here that in the leak group, the average units were 4.6 and the non-leak group was 4.5, although it's not statistically significant. 1/3 of our patients received greater than the 6-unit threshold that has been previously established. 11.7% of our patients, or 7 of the 60, had an anastomotic leak. However, not a single variable we compared between the leak and no leak group was found to be statistically significant. This included multiple different demographics, injury characteristics, smoking, BMI, transfusion volumes. Therefore, transfusion of the 6 units was a meaningless predictor of an anastomotic leak in our patient population. In the era of hemostatic resuscitation, transfusion volume does not appear to be associated with risk of anastomotic leak following destructive colon injury. However, shock may still be a risk factor for anastomotic leak. This transfusion volume does not appear to be useful in the modern era in respect to deciding whether or not these patients should have primary anastomosis or undergo diversion. Thank you so much for your time. I welcome any questions. Yeah, absolutely. So we did look at that. There was no statistically significant difference between hand-sewn or stapled anastomoses. And then for your second question, 9 of the patients had damage control laparotomy and then subsequently received an anastomosis the next day. None of those patients were in the leak group. Yes.
Do you have any data in renal ICDs, whole blood areas?
Yeah, that's a great question. So there was a period of time where whole blood was available at our institution. The years that are there kind of pick up in a period of time where there was whole blood and sometimes where there was not. Currently, at this moment, we do not use whole blood in our institution. Yes.
And if we're not going to use transfusion volumes to determine whether or not to convert someone, how do we decide to do that?
I think that looking at other indicators for shock would be important. We did look at lactic acid because that was the data we had available. There was a mean in lactic acid on admission of 4.2. This was not statistically significant in either group either. I think it might be useful to look at other surrogates, maybe base deficit on initial ABG versus postoperatively, et cetera, and kind of those trends that might be helpful. Yes. So.
Was a surrogate for shock, just so you know, that's why that's put in there. And it's easy. You don't have to calculate ISS, or you don't have to do some. There's many problems. I was actually going to say previously everyone should use lactate, but there's many problems with lactate and base deficit in this setting. A bunch of false positives. And, you know, so, and there have clearly been major differences over the past 30 years with respect to, I think, resuscitation strategies. And I'm biased, but I think those resuscitation strategies are better and lead to better resuscitation with less bowel edema. Okay, so those are all things that have changed. I think, you know, we had a whole session, it wasn't on leaks, but we talked about leaks for an hour in the session yesterday. I think you know, leaks still are influenced by the physiologic condition of the patient. And so I think there has to be something there. I'm just going to say I think lactate or base deficit is just not going to, it's probably not going to work. But there have been substantive changes in resuscitation. So I don't know, I'm a little skeptical. To me, it's a great question. I think you have to have something to replace it, to give people guidance on what to do. And you know, Tim Famey is going to talk about this at the AASD, but there are, you know, some people who don't believe you should never do an ostomy. You should just never do one. They'll all do fine. I'm skeptical of that. Quite skeptical. So, but it changed. We need something to replace it. So what to replace it with? You already answered.
Yeah, I think that's a great point. And I think this is what makes this clinical question so challenging is what do you use to replace it? And if this is not statistically significant, then what is? And we did look at, you know, whether the total components was statistically significant, and it didn't show to be either, you know, including cryoprecipitate, FFP, et cetera. And so I think that, you know, moving forward, kind of just using a multitude of different markers and data during the resuscitation of the patient is probably the best answer, but that's, you know, not necessarily realistic either. So I hear what you're saying. Absolutely.
That doesn't give me pretty good guidance. You know, they look pretty good. Okay.
Yeah. I think the bigger thing is watching these, if you decide to anastomose these patients, right, if we don't have a clear marker for what that, you know, resuscitation threshold is, you know, really good post-operative vigilance in, you know, ensuring that when these patients become tachycardic, when they have spike a single fever, that we're, you know, doing the, you know, due diligence to make sure that we're catching these leaks sooner than later. 6 of the 7 did. Yes. No, we did not. And that was another thing that kind of came up during our discussions post hoc as well, was, you know, is a push of phenylephrine here or there, you know, at the time of the anastomosis, is that impacting kind of what we're seeing here in any of those trends, you know, statistically significant? It would be interesting to see.
We're out of time. Excellent discussion. Thank you.
Thank you. Next session is about to start on the Alexander Room.
Worked out.